Good morning, Mr. Moawad.
Good morning, Mr. Diab. You're rising early.
I know. How are you?
I'm all right. How are you?
I'm good, man. When are you coming to Bristol?
Tomorrow morning? Mr. Jones is here. Good morning, Mr. Jones.
Morning, Nader.
Good morning. So I think let's give it another 30 seconds or so and then we'll start.
Yep, that's absolutely fine.
We might want to start. Is that okay, Mr. Jones?
Yep. Yeah.
So, good morning, everyone. I hope, thank you very much for joining us. We welcome Mr. Jones from Royal Victoria Hospital, Northern Ireland, to give us a talk today. So I'll leave the floor to you, Mr. Jones. Can you please share your screen?
Good morning. Thank you very much for the welcome, Nader, and welcome everyone who's logged in this morning. I believe you've been going through a number of topics recently, including recently looking at the mediastinum, and Nader asked me would I look at the topic of mediastinoscopy. So the title of our topic this morning is Mediastinoscopy, Why and How? Essentially, if we just take a brief recap, I know this is going to be a simple guide for all of you who are logged in this morning, but we can see the area that we're going to make the incision for a mediastinoscopy about 1 centimeter above the sternal notch. And the goal is that we're going to get into that, go through the pretracheal fascia, run down in front of the trachea and biopsy the lymph nodes. The reason we're doing it has probably changed a little bit over the years. Certainly mediastinoscopy, when I was a trainee, was a lot more common. And then we got the introduction of PET scanning. So historically, we were looking at CT scans with a lymph node greater than 1 centimeter. to give us an indication of when we wanted to do a mediastinoscopy in the setting of a lung tumor. So in lung cancers now, we've got the advantage of PET scanning, and it is very sensitive. It is highly specific and has a good negative predictive value for peripheral tumors. A few things just to caution. So a number of patients who may have N1 disease on their PET scan will also have pathological N2, even though the scans may not show any obvious lesion. Tumors that are slightly bigger, or indeed tumors that have a high SUV, the negative predictive value is slightly lower. So we need to keep that in mind. And for central tumors, again, those that have a negative media sign on PET scanning, it's very low for the peripheral ones and much higher for the central tumors. So those are a few things to caution when we have a PET scan that seems to be reassuring. We still need to keep in mind the other issues to raise the question, should we still be thinking about doing a mediastinoscopy? So in broad terms, if we've looked at how we're going to do it with that first slide, this might summarize why we're going to do it. So if we think about non-small cell lung cancer, locally advanced non-small cell lung cancer, the reason here is that we may want to confirm that we've got a tumor and confirm that there is not a curative treatment option for this patient. If we've got early stage non-small cell lung cancer, the reason for the mediastinoscopy will of course be if there are any queries that we need to confirm that we are indeed early stage and can proceed with a potentially curative treatment option, including obviously lung resection. Or indeed if there's an intermediate suspicion of N2 or N3 disease, and we'll come back to that later. The thing that we should also keep in mind is that there are diseases other than non-small cell lung cancer that will present and for which we will want to do a mediastinoscopy to get biopsies of lymph nodes that raise suspicion on CT or PET scanning. And obviously the common scenarios that we end up in that situation are patients that may have a lymphoma where we're trying to get a diagnosis, or some form of granulomatous disease, the most common obviously being sarcoidosis. So there may be a number of other features that either the hematologist will be contacting us or the respiratory physicians outside of a lung cancer MDT, and they're looking for some help in terms of trying to get an answer as to what is the disease process that is going on. We have mentioned that we need to assess for locally advanced or early stage non-small cell lung cancer. I think it's important that we remind ourselves what those are. So apologies for this fairly busy slide, but in my defense, as people often say, I didn't create this. Those that did, however, are very proud of it. It is the 8th iteration of the TNM stage. So let's look for a moment at the T staging. So if we look at T1 tumors, we've got the small tumors less than 3 centimeters, and obviously this has now been broken down into a number of other subgroups. The minimally invasive and superficial spreading tumor, I have to confess, are not things that we come across very frequently. So looking at size, we've got the T1A, less than a centimeter, T1B, between 1 and 2 centimeters, and T1C, greater than 2 centimeters, but less than or equal to 3 centimeters. We've then got T2 tumors, so tumors that are extending up to 5 centimeters, or, and don't forget about these important ors, so the tumor that may be involving the visceral pleura, tumor that may be involving a main bronchus, but not the carina, and tumors that have atelectasis extending to the hilum. So even if the tumor was smaller but was causing one of these problems, we go for the highest grade of the staging system that is applicable. So to be clear, a 1 centimeter tumor that was involving the visceral pleura would actually be staged as a T2. So in terms of size, however, again, between 3 and 4 centimeters for T2A and between 4 and 5 centimeters for T2B. T3 tumors are the larger tumors in terms of size, so between 5 and 7 centimeters, or, and we need to keep these in mind again, same thing applies, the highest applicable stage is the one that will be the thing that carries the staging. So invasion of the chest wall, and remember that does not have to be right through ribs, but as long as it's invading the chest wall beyond the visceral pleura, then we're counting a T3. Pericardium, phrenic nerve, and in fact, this issue just arose with ourselves just last week. We had a patient with a tumor just lying at the confluence of the chest wall and the pericardium and was invading both. Thankfully, we managed to get a complete resection, an R0 resection in that situation. Phrenic nerve may be at risk. We try to preserve it if at all possible. Obviously, again, we need to aim for a curative resection. So if it needs to be sacrificed, it needs to be sacrificed, and we can think about the other treatment options that are available for that. So we've got size for T3, we've got the invasion of other structures, or indeed then separate tumor nodules within the same lobe. T4, much larger tumors, so tumors larger than 7 centimeters, or again, the tumor that invades other structures. So now we're thinking about invasion of the mediastinum, diaphragm, heart, the great vessels, recurrent laryngeal nerve. The nerve itself could be sacrificed, but the fact that it's involved probably indicates that we're involving some of the great vessels at that stage. Also needs to be borne in mind. The carina, trachea, esophagus, spine, or we mentioned tumor nodules. Now we're thinking about tumor nodules in a different ipsilateral lobe. So T4, tumor in a different lobe on the same side, T3, tumor in the same lobe. So those are the T stages. They're good to set the scene for when we may want to think about when we're doing a mediastinoscopy, but perhaps more relevant to us is the end staging, and not obviously the best situation to have no regional node metastases. N1, ipsilateral pulmonary or hilar lymph nodes. N2, ipsilateral mediastinal nodes, or subcarinal. Obviously, subcarinal is in the midline, so we're faced with that uncertainty, but they're still qualified as N2. In contrast to N3 nodes, where there are lymph node metastases in the contralateral mediastinal nodes or hilar nodes. So they've crossed to the other side, left-sided tumor, but right-sided hilar lymph nodes, N3. Or supraclavicular nodes is the other situation where we'll be looking at N3 nodes. Just for completeness, we'll not dwell on it long. M0 will be the majority of, well, hopefully all the patients that we're dealing with, but there are, we need to keep in mind that patients who have malignant pleural or pericardial effusions, patients who have pleural or pericardial nodules or tumor nodules in a contralateral lobe. So a right upper lobe tumor with another nodule in the left upper or lower lobe that is confirmed to be a cancer related to that would be M1A. Obviously, the slight uncertainty in all of that is the potential for synchronous tumors or metachronous tumors. So we need to not be absolute in that. We need to keep that in mind if that strange way, particularly with some of the adenomas that we may be dealing with. M1B, a single extrathoracic metastasis, M1C, multiple extrathoracic metastases. So that's an overview of the TNM staging as it now applies. Just to emphasize, the dramatic thing is looking at size. So if we look at these this graph showing survival, we see that moving down the list, we've got tumors less than 1 centimeter, about a 90% 5-6 year survival, dropping down slightly then with the slightly bigger tumors, 2 centimeters. I should say the figures here relate to previous iterations and were used in terms of deciding whether we would move to the 8th iteration of the TNM staging for lung. So tumors up to 3 centimeters, 4 centimeters, 5 centimeters, 6 centimeters, and 7 centimeters. Just keep an eye on the numbers involved in these. So relatively small when we're getting to the larger tumors, relatively small numbers when we're dealing with the very small tumors, but large numbers in between. So that is an idea of why we've moved in the 8th iteration to a multitude of different size criteria for the T staging. Just a little bit more information on the N staging. Again, so we've mentioned N0. Obviously, NX is the other thing that we may have to deal with where we cannot assess the lymph nodes, and sometimes that has to still be a pathological criteria, or when we're finished with staging, if we've not biopsied. So that's one good reason sometimes for doing a mediastinoscopy. N1. Suggestions that it may be worthwhile looking at single station N1 involvement, N1A, or multiple station N1 involvement, N1B. And likewise, N2 can be classified in a number of ways. N2A1 is a single station N2 without N1 involvement, so-called skip lesions. So to be clear, we've got a tumor within the lung. We have no evidence of any N1 lymph nodes, but we do have a single station N2 suggestion. That would be N2A1. N2A2, single station N2 with N1 involvement, and then obviously the more concerning scenario of N2B, multiple station N2 involvement. And we mentioned previously N3 lymph node involvement. Where's the evidence for this? Well, just broadly speaking, first of all, if we look at the survival for early for tumors that are not metastatic, so M0, but without looking at the T-stage criteria, broadly speaking, N0 disease, 60% 5-year survival, dropping down to 37 for N1 disease, 23 for N2, and much lower than for N3. Coming back to the subdivisions that we've talked about, again, almost a 60% survival for the single N1, the N1A. If we have multiple N1s, that drops down significantly lower. We're down to about 50%. It's about the same as a single station N2. So that gives us some of the reason for justification when we're suggesting that single station N2 disease, if we think we can clear the disease, that we'll often be contemplating a curative surgical resection for that patient. So multiple N1 and single station N2 have a similar survival. Obviously, if there are N1 nodes as well, then we see that N2 survival drops even with a single stage, and lower again when we get to multi-station N2. Just as a historical background to some of these, way back in the 70s, almost prehistoric, but not quite, we're finding that the survival is quite poor. Obviously, remember there was really no other clear imaging criteria available at that point. Bringing ourselves up more recently, perhaps we look at the 1982 studies at mediastinoscopy when N2 was negative, 24% 5-year survival, as opposed to doing a curative resection with positive mediastinoscopy, the survival is much lower. So that again gives us the encouragement sometimes if we come across unsuspected N2 at the time of surgery, it may still be beneficial, and the evidence would suggest that if we can achieve complete resection, it is still beneficial to proceed with the planned potentially curative resection, but there are exceptions to that that we need to keep in mind. And again, just for single or multiple N2 disease at the bottom, if we see that brought out more clearly in a more recent study, looking at a slightly different group. Again, single station N2 disease, survival 20, well, if we go to 5 years, we're looking at about 50 versus less than 20% 5-year survival. Okay. Let's just take a quick run through that again to remind ourselves what we're looking at. So pictorially, stage 0 we'll not dwell on. Stage 1A, we're looking at the 1A, 1B, 1C tumors, the small tumors with no lymph node involvement. I mentioned the other sub-criteria. Stage 1B, we've got the either the tumor that's got one of those size criteria, central or visceral, or just looking at the size of the tumor, but again, the nodes are not involved. Stage 2A, we've got the larger tumor, but again, nodes are not involved. Now we move on to stage 1B. So we're now getting lymph node involvement for the majority of these. The only exception are some of these large T3 tumors, sorry, not large, but the T3 tumors of whatever criteria with no lymph nodes fall into stage 2B. As do obviously the T3 with the satellite nodules. So T3 tumors with no lymph nodes are stage 2B, but all the other ones will be N1 disease. Okay. So we've looked at stage 2B, looking at stage 3A. We are now facing a number of different scenarios. So we're facing the if we take the early stage T tumors, but they've got N2 disease, then they're stage 3A. If we look at the T3 tumors, they've got N1 disease. So T3N1 will be stage 3A. T4, it doesn't matter whether they've got lymph nodes or not. If they're T4, then they're in stage 3A, as long as it's early stage lymph node disease. Obviously, moving on, stage 3B, where we've got the N2 disease, essentially, whether it's in T3 or T4, or indeed the only other group that's falling into that 3B staging are the smaller T-stage tumors, but sadly they now have N3 disease, and they're also classified as stage 3B. Stage 3C will not dwell on, but big tumors with N3 disease. Metastatic disease, we've already mentioned. And should just point out, if you want to go back through this reference, an excellent article to summarize, and that is where these various figures and tables have come from. So an excellent resource to be well versed in what the TNM staging is, to know what we're dealing with. This is another way to look at that. So again, we've been talking about the different ways of grouping these when we were looking at the diagrams, just to run through the effect on survival. So the 1A, stage 1A tumors have a very good survival. We can see 80 to 90% 5-year survival. Stage 1B, so the slightly bigger T tumors, but still negative lymph nodes, slightly worse survival. 2A, which is the T2B tumors with no lymph nodes, and then the bigger group T2B, which are either the slightly larger tumors or the small tumors with N1 involvement. They have, again, a 5-year survival of between 50 and 60%. 3As, then we're getting down to the 40% 5-year survival. So these are the important issues where we're sometimes trying to find out, do we have N2 disease or do we not? This is an issue that we're trying to work out because it's going to make a big difference, not only in terms of prognosis, but it might be making a difference if there's multiple N2 diseases, N2 stations, whether we should actually be operating in this patient or not. And again, that's emphasized with the 3B tumors, where we've got the large tumors now. We're thinking again, do they have only N1 disease, or do they have N2 disease? We need to get this clear in our minds as to whether we're going to be doing the right thing for them, and it makes a huge difference to their prognosis. I should say these are not the figures that we should necessarily be quoting to patients in terms of what we expect their survival to be. These were the historical figures that were used, Peter Goldstraw among others, looking at this data between 1999 and 2010. And obviously, if we look at survival by decade of data, it seems to improve each time. So there are a number of other developments. So these are historical data used to inform the current staging system, but we don't know what the current survival for patients presenting today will be. But we have reason to believe that it could well be better than that, because historically data has improved over time as further treatment options, whether those be medical care, surgical care, the options to treat patients with the various chemotherapeutic agents. So we expect that survival is probably currently a bit better than that for the various stages. So we're going to consider mediastinoscopy. We need to think again just what the lymph nodes are that we're going to be having to explore. This again is a fairly busy slide. It's from the Detterbeck paper. Obviously, station 1 is above the clavicle. Station 2, so paratracheal upper. 4, paratracheal lower. We've got the prevascular and the retrotracheal, which station 3, which we very often don't get too involved with as surgeons. Need to think about the ones again that we can't really access from a standard mediastinoscopy. We may have to consider other options for that. We'll come to that later. But station 5 and 6, subaortic or AP window, and then the para-aortic lymph nodes, station 6. Just to mention in passing, we often consider that a left upper lobe tumor with just these nodes involved do seem to have a very good outcome, and that's a particular instance of the single station N2 with no intervening N1 disease. And then obviously we've got the subcarinal lymph nodes below the carina, not unsurprisingly, paraesophageal station 8, and the pulmonary ligament lymph nodes down at station 9. And then obviously once we get into double figures, we're thinking about the N1 nodes. Hilar are usually the only ones that we might think about. 10, sometimes called hilar or sometimes called tracheobronchial, where that sort of confluence, and we'll come on to that later, and then the other stages which will be picked up during our lymph node dissection during a surgical resection, whether it be thoracotomy or Vats. So that's some of the reason as to why we will be doing a mediastinoscopy. We need to keep all of that in mind. So we've got a very, what seems to be a very simple operation, doesn't take all that long, but the process by which we've arrived at deciding to board that patient and bring them in for a mediastinoscopy will have required the use of that information that we've just thought about. It's important that we keep that rationale in our minds so that we're operating on appropriate patients. So how are we going to do it? Well, here's a stylized diagram. Obviously, the patient will have had their incision made at the sternal notch. We'll have managed to dissect some of the tissues. I have another slide to show that in a moment, but we're running the mediastinoscope down basically below the pretracheal fascia, right in front of the trachea, and we can usually see the lymph nodes. The difficulty is that we can also see a few other things. So we may see, or indeed be able to feel, the innominate artery. We'll see a few lymph nodes, as we can see on the screen. We will probably be able to see the azygos. We may see the aorta. We may see the pulmonary artery. So these are all important structures, and when we come to think about complications, these are things that we need to keep in mind. Obviously, the one that we all get worried about and the one that we warn every patient about is the fact of causing severe catastrophic bleeding that would require opening of the chest. And that's the phrase I often use, you know, a bit like we have to do during heart surgery. Now, that's if we were to cause a catastrophic injury to the pulmonary artery. Most other things can be dealt with by packing and so forth to some extent. And there are a number of other complications that we'll come to in a moment or two. But there, we had one anaesthetist, I remember calling his anaesthetic trainees across and looking down the various things, and his expression was, "That's tiger country." So there are a lot of things that we can cause damage to. We need to be careful at what we're doing. And indeed, we need to look very closely at the mediastinoscope that we're using. We just changed some of our equipment. They're slightly, newer ones are slightly bulkier, some of them slightly sharper edges, and it's not impossible to cause problems to trachea. For instance, if the scope doesn't run freely past it, then the traction in that, or the increased size, if we haven't made a big enough incision, could cause injury to the trachea and put traction on other structures. A little bit better look at what the lymph nodes are then. We've mentioned these ones above the clavicles, the station 1 disease, so we'll not really be dealing with those at mediastinoscopy. We're thinking more about the paratracheal upper, the paratracheal lower, perhaps station 10, and not infrequently we're looking for station 7, subcarinal. Remember, we're not really going to be able to get at these through a standard mediastinoscopy. There are descriptions of extended mediastinoscopies, but there are other ways that we can sometimes biopsy those if we need to. Let's just look at these a little bit closer if we can. So it's important to keep these definitions in mind. So the lower border of level 1 is the clavicles bilaterally, and in the midline, the upper border of the manubrium. So let's just go back. We're looking at station 1 above the clavicles, or if we've just got the manubrium dipping here, we're sitting above that. Another important boundary, that between 4R and 4L, is the left lateral border of the trachea, not the anatomic midline. So I'll just say that again. The boundary between level 4R and 4L is the left lateral border of the trachea, not the anatomic midline. So if we look at this diagram, these lines are not just drawn in an arbitrary place. We've got 4L, but it's to the left of the trachea. Once we go beyond the left border of the trachea, we're into 4R territory. So it's not down here, it's not the midline, it is the left lateral border of the trachea that is the marking point between a 4L and a 4R, an important definition. Another definition that we need to keep in mind is the boundary between level 10 and level 4 is on the right, the lower border of the azygos, and on the left, the upper border of the pulmonary artery. The reason that's important is obviously this is single digits, N2, double digits, N1. We've got a difference in our stage criteria, prognosis, remember all the things that are going on with that. So we need to know where we're biopsying. And not only that, we may end up finding this discussion going on in our MDTs. It may be very relevant for the patient that's been presented with EBUS, and we want to know, was it beyond the azygos or before the azygos? This is going to be important when it comes to making that decision as to whether this patient is operable. So remember the other means of biopsying, and that might be relevant for us to know what the definitions are when we're informing the decisions in the MDT. So as we said, if we're above the azygos, we're looking at station 4. If we're beyond the azygos, then we're looking at station 10. So I would encourage you to look at these ideas, look at these definitions, keep them in mind. They are important distinguishing factors. So coming back to that early slide that we had, and we're nearly there. Coming back to that early slide, I'd said that sometimes we think we've got locally advanced non-small cell lung cancer. And we're worried that there may be a nodal involvement. We're trying to decide, can we operate or can we not? Well, I've just mentioned some of the other options open to us, endoscopic ultrasound or endobronchial ultrasound, EBUS or EUS. EBUS obviously very commonly done nowadays, very often, at least in our centre by the respiratory physicians around the province with the various meetings. So they will very often be able to give us answers, and that's one reason that we're doing fewer mediastinoscopies. We've already got a PET scan, we've got suspicions that we think this might be locally advanced, and we need to confirm what the answer is before reaching a conclusion on this, on how to move forward. But the result has come back and the EBUS is negative. I think in that situation, if we still have a strong suspicion, and this will be an MDT discussion, we still have a strong suspicion that this patient may have locally advanced disease, then in that situation, the mediastinoscopy with the bigger biopsy, the opportunity to get out a little bit more tissue may well be something that's worth doing. And in that position, we're trying to get a diagnostic procedure to help with staging to decide whether or not this patient has indeed got locally advanced cancer. So the other option we talked about earlier on was early stage lung cancer. And we've pointed out that very often we don't need to do a mediastinoscopy if we've got a peripheral tumor, if we've got a very small tumor, if we've clearly believe that there's no N2 disease on CT or PET. The strong advocates of more aggressive policy on mediastinoscopy would say that there's often a rate of unsuspected mediastinal nodal disease of around 10%. So some would advocate that we should be still doing mediastinoscopies on a more aggressive policy. That is something that is probably there for discussion, but it's just to keep in mind that usually in these situations that we've described, the peripheral small tumors that have no evidence of N2, we probably will not be doing it, and that would be the usual answer, but there may be exceptions to that. The other thing that we need to keep in mind is for left-sided tumors, if there is any query about a right paratracheal being involved, then it will be important that we assess that, because that would turn that patient into having N3 disease. And those, again, may be even more relevant in the current era of, well, for thoracotomy, it's still going to be problematic, but some of these other things we may want to think about the options that are open to patients having Vats surgery. There are some patients where we have no clear evidence of N2 or N3 disease, but there are things that will make us a bit more suspicious. So the patient with the central tumor, PET scan doesn't show N2 disease, you might still want to do your mediastinoscopy because there's a reasonable risk that those patients could have it, and it's going to make a big difference. The patients who already have got significant N1 disease visible on their PET, there's a higher risk that of N2, might be worth doing the mediastinoscopy. The tumor that's very large, even if you don't have lymph nodes, they might have N2 disease, a better capture rate if we are doing mediastinoscopy. So those are a few patients where if it's going to make a big difference to the outcome, perhaps taking the whole patient into account with their fitness, trying to work out, are we really doing the right thing by offering a potentially curative thoracotomy on this patient or not? We want to know what we're dealing with. It's often better to do the mediastinoscopy early on. Sometimes it might even be that we've already done the EBUS and we've got it negative, and you're still wanting to say, like, this is a big tumor, the patient's maybe not all that fit, I would like to be absolutely certain. So you do the MEAD. Others would suggest that we sometimes can get evidence to suggest that there may be increased sensitivity of surgical staging, but that is, the differences are not dramatic. The other systems are very good at this stage. I mentioned at the beginning that we've got non-small cell lung, non-cancer disease, or at least non-lung cancer disease. There could still be malignant processes. Lymphoma is the common one. The big non-malignant ones are the chronic granulomatous conditions, of which I said sarcoid is the most common. And we need to keep in mind that for a number, particularly if these patients, that there may be a suspicion of sarcoid, sometimes we get the biopsies back and they're not diagnostic. We have to warn patients that we still may not be absolutely certain what is going on, but we can let them know that at least it will be more reassuring. And sometimes the respiratory physicians will be reviewing those. Sometimes we'll be discussing them again and perhaps deciding, look, we've tried once, maybe it's worth another attempt if we think that there's another biopsy that might have helped us, or perhaps even considering going for a different lymph node station if need be. I've given a fairly stylized diagram at the start as to how to do it. Let's just remind ourselves again. So we have the idea of where our incision is going to be. So just about 1 centimeter or so above the sternal notch. We're going to try and retract the, go between the strap muscles, retract it laterally, and then try to incise the pretracheal fascia. Still very often to be able to dissect that freely with your finger in front of the trachea, and then a mediastinoscope can be inserted down with biopsy forceps. What can go wrong? Thankfully, the majority of times, very little, and usually it is a routine procedure. Usually the patient comes in either that morning and goes home that evening, or may come in the day before, may have to stay over. But things can go wrong. Obviously, there are anesthetic risks, cardiac arrhythmias and so forth, as well as all the other issues. The reason I mentioned the paraneoplastic syndromes, I have great memories of when I was a registrar. I had a mediastinoscopy who ended up having to go to intensive care for ventilation. So she had a paraneoplastic syndrome. Quite interestingly, interesting lady, she called her tumor Fred and was very fond of it, but sadly it was causing her a lot of trouble, and she had a myasthenic paraneoplastic syndrome, and just we could not get her to breathe for quite a while, and had to be ventilated for a day or two before getting out of hospital again. Uncommon, but just keep it in mind. These are the things that we're going to be thinking about a lot more. Bleeding is the one that we've mentioned to everybody. Majority of times that there's bleeding, as I say, we can pack, and keep in mind as well the issues around redos. Sometimes following previous cardiac surgery, it is still possible to do a mediastinoscopy. The risks are not huge, and if there is scar tissue in there, it often helps with packing and so forth, or adrenaline swabs, but that can all be done to try and stem the flow of bleeding. But I've certainly been called to theatre to help colleagues on a couple of occasions where there's been bleeding after redo mediastinoscopy for some reason or other. I hesitate to say that I haven't yet had to open a chest for an injury to the PA. It has happened a couple of times in the hospital, but it's just something that we always need to be cautious about. Vocal cord palsy probably happens less than 1%, but it's still something that I would now warn all patients about. That's because I've experienced it. So vocal cord palsy, it's a big impact on the patient. It may be traction. It may not be a direct injury to that side. It can have happened on the other side, but vocal cord palsy is a concern. Pneumothorax, the lungs are not that far away. And we mentioned earlier about injury to other organs. Not seen esophageal injuries, I have seen tracheal injuries. So say the age of a scope can catch a tracheal rings. You just need to make sure where you're, don't push blindly. Chances are you will be stronger than the trachea and you will win. So we've got to be cautious about the trachea and thoracic ducts, another structure that can be damaged. I mentioned there's an alternative procedure if we're looking at trying to biopsy 5 and 6. So the anterior mediastinoscopy, either taking out a portion of a ribbon and then going through the back of the cartilage, or going in between ribs, making sure that we control the internal mammary vessels, trying to retract the mediastinal pleura out of the way, and then getting down to where we want to biopsy the lymph gland, so-called Chamberlain's procedure. There are a couple of newer developments, VAMLA and TEMLA. One of the suggestions for using these is that they may have a role, particularly with Vats surgery, to get better mediastinal clearance and enable some of those lymph glands to be biopsied or removed more safely by these techniques than during the Vats lung resection. This is just a view from it with the scope in place. Obviously, the grasper's dissecting out a lot of the tissue, and we're left here with the trachea. You see the SVC. We've got, as we mentioned, the right mediastinal pleura along here. So we're able. It is possible to dissect out a lot of the nodal tissue by these newer techniques. And some of the indications for them, say, maybe pre-resectional lymphadenectomy in Vats lobectomy, or perhaps with bilateral synchronous lung tumors. You may want to check what's going on with the mediastinum to find out, is it synchronous, or are they is it metastatic disease? And then some of the other ones that we mentioned earlier with these indications for the bigger tumors or the already present N1 disease. Thought to have a slightly better sensitivity. Goes to show when you're publishing papers, just make sure that you read the proofs all the time. Unfortunately, it was a negative predictive value is what they were trying to show in this publication from Mediastinum in 2019, but showing that there was slightly better negative predictive value from these more aggressive techniques than standard, well, essentially video-assisted mediastinoscopy, which is what we do currently. So overall, staging can be done to plan the treatment for that individual patient, to indicate the prognosis, as we said. Remember the difference between N1 and N2 disease or multi-station, to evaluate treatments, to find out what we're doing, to facilitate exchange of information among centres and among countries indeed, and to contribute to research and registry. So these are all important factors for why we want to get it right, why we want to know what the outcome is for the staging, not just for the patient, but to make sure that as a treating centre that we're actually comparing like with like, that we're not finding bad outcomes in our N1 disease patients simply because we didn't fully assess them and didn't get the diagnosis of the N2 disease that was actually present. So it is important, and to say it's important to contribute to research and registries. There are other ways to get into the mediastinum. So here we've got a way with the chest open, a fairly large knife in place. So there was a bit of exploration of the center of the chest going on in this situation. Thankfully, the knife handle was the wrong way around, or the knife blade was the wrong way around to cause too much of an injury to the heart, which has been held out of the way. A nick in the diaphragm, IVC was thankfully just about spared, but that was how the patient presented. Not the best way to explore the mediastinum, I would suggest. I think we'll stick with some of the other ones that we've just mentioned. Okay, thank you, Nader.
Thank you very much, Mr. Jones, and thank you really for joining us at this early hour and taking the tedious task of taking us through the TNM staging of lung cancer. That must not have been easy, but you made it very simple. I'm not sure if we've got any questions in the chat box, so I was just wondering if anybody got any burning questions, just unmute themselves and ask. In the meantime, do you think, Mr. Jones, is there any condition that would preclude cervical mediastinoscopy? A patient you see in the clinic and say, I don't think mediastinoscopy will be possible. Like we had a previous case of patient of recurrent goiter surgery. Would that something be in the way that you would really try and avoid a mediastinoscopy in, or not particularly?
A very good question, and obviously something that needs to be thought about in detail. Peter Goldstraw, so Professor Peter Goldstraw has published a number of papers looking at the safety of mediastinoscopy in redo situations. A lot of his work did document it in redo cardiac surgery, so after previous median sternotomy. So that's a group of patients that will have significant scarring, and yet with all of that, he has said there was a very low incidence of complications. I've done a number of patients where there's been previous operations and of that nature. Obviously, the more scar tissue there is in the neck, and certainly I think previous surgery for a goiter would raise some concerns, and it would be a case-by-case basis. I think you'd have to weigh up what the risks are, and I would probably be particularly warning the patient of the slightly increased risks of some of the complications, be they vascular or neurological, traction on nerves and so forth. So I think it would have to be borne in mind. The other group, I'm not sure that we would come across it very often, but a patient who had previous radiotherapy, again, that always causes a degree of scar tissue and can make planes very difficult. So, we perhaps would just be weighing up closely whether we thought mediastinoscopy is the best option, or would the combination of whatever we've got with our negative scanning to date or positive scanning and EBUS, EUS attempts might be the way to proceed.
Excellent, thank you very much. I don't think we have got any burning question.
I do.
There is someone.
Yeah, I do have a question. This is Sean Bello from Bristol. Many thanks, Mr. Jones, for a very comprehensive talk. The question I have really is slightly off topic, but for patients that haven't had a mediastinoscopy pre-op in your, what guides your decision on the extent of the lymph node dissections during the surgery, as in it's just sampling or complete mediastinal lymph node dissection?
Okay, that is a very good question, and I would also agree that it's probably slightly off topic, so it may be a bigger topic that you want to address at some point. I mean, there are those who will advocate systematic nodal dissection to try and get an appropriate number, and there are figures that are quoted of the appropriate number of lymph nodes that should be sampled. It probably also requires the communication with your pathology team as to whether or not they want you to dissect out each of the individual nodal stations that will be coming during your resected specimen. So keep in mind, you'll have a number of N1 stations that will be present, and some of those it may be easy to lift off and send off as separate specimens. And then the question is, we should certainly assess a number of the N2 stations, and that will be influenced. I think the aggression with which we go looking for those will be dictated by the size of the tumor, but it is important to know that the relevant N2 stations are either positive or negative. So, for a left upper lobe tumor, we will want to know what those AP window and para-aortic lymph nodes are like. So it's worth incising the reflections at that stage to look and see. And obviously, again, paratracheal lower, usually we will want to see, is there something present in that area, or the subcarinals again to get that. Now, perhaps the other issue that comes into play then is Vats versus open. So a number of the earlier Vats papers would have suggested that the lymph node yield was lower with Vats surgery than it was with open. That probably reflects the confidence with which Vats surgery is being done. And I think there probably is still a range, but we need to keep in mind that, again, depending on the centers, it may be that the Vats surgery is being done for what we firmly believe to be the lower stage earlier tumors. So there may be less of a need to be going dissecting within the mediastinum in that situation. But that's another whole debate, I suppose, on where the full extent of the Vats surgery should be and what tumors we should be attempting to resect by Vats to ensure that we're adhering to the oncological principles of trying to get beyond the last nodal station. So, you know, it is reassuring to know that we've taken out so many nodal stations that even if there's been 1 or 2 N2 stages present, that the one beyond that is still clear, and that may be more giving us more confidence for the future. Hopefully that tries to address the question to some extent, Sean.
Yeah, it does. Thanks a lot.
I think Mr. Diab has got a question. He's raised his hand, so you've got 5 minutes, Mr. Diab.
Yeah, sorry. Hello, I'm Mohammed. I'm SC6 at Bristol.
Okay.
I've got a question, and I understand the logistics behind it is difficult. But is there a role for performing a Vats staging and having a pathology in the operating room and performing the histology, and then deciding then and there on proceeding or not? I understand a frozen section would give an inconclusive result or not true, but if you have a pathologist in the operating room, this might help. I don't know if it's a possibility instead of going into 2 general anesthetics.
No, an excellent question again. And that is, I suppose it's something that varies depending on the centre. So in our centre, we don't have the privilege of having a pathologist in theatre. If we're really looking for results, maybe someone from the theatre team may be dispatched to go to the pathology lab and stand by while those results are taken. Whereas I know that there are other centres where a pathologist will be present on the floor and able to give much quicker results than the frozen section ideas. I mean, we do need to keep in mind that frozen section can be wrong. I've had 1 or 2 patients where what we got on frozen section transpired not to be the case. So I usually qualify that to patients to explain that to them preoperatively, that if we are doing a frozen section, so for instance, someone that didn't have a biopsy of their tumour beforehand and we're doing a wedge and then proceeding, I need to warn them that usually the definitive pathology is the same as what we find in theatre, but not always. The other thing obviously we need to keep in mind is that sometimes we can go the other way. I've had to do lung resections for what has been described as a lung cancer. And when we get the definitive pathology, it transpires that it was a chronic granulomatous condition, TB in that particular case. That's something that we're acting on the best information that we have, and obviously everybody goes back and reviews their pathology. But your specific point is well made. I think there are a lot of centres that have the privilege of having that real-time frozen section service, and I think it is an excellent addition, but it does require significant logistics and probably depends on the size and capacity of the units to support that. Thank you.
Thank you. Thank you for a very well talk.
Thanks again, Mr. Jones. Hopefully you will become one of our common speakers, I hope. I hope it wasn't very difficult for you. Thank you very, very much, Mr. Jones. And if you don't mind, we'll be sending a link for the recording to all of the trainees that have attended so that they can look back. And if they missed anything, they have a chance to have a recording of the talk, if that's okay with you.
That's absolutely fine, Nader. And thank you once again for the invitation. And sorry that we're maybe talking about what seems to be a relatively small topic, but it's I say there are a number of things that are very relevant, and
absolutely, I think
that are important just to focus on. So thank you.
Thank you again. It was very well covered, and hopefully see you very, very soon.
Okay. All the best, Nader. Thanks again.
Thank you.
Bye now.